right, y'all, it's 3 o'clock, and that's the time we're stated to start the last workshop of the day. It's going to be the best one you've been to all day, right? So get ready for a party. It's good. So the speakers are going, what? So I'm Justin Lindstrom, and was on the steering committee for Pathways to Hope Conference. We're so glad that you are here at our 7th conference, and the first time that it's gone nationwide to 18 other cities around the country. Pretty awesome. So something that San Antonio can be incredibly proud of. So tell your friends about it. We'll be doing it again next year, the last Friday and Saturday of August. So same time, same place. Does everyone understand the CEUs? Because if you've been to 2 other workshops, you've got the spiel. Anyone need it repeated? No. No. So great. We will be ending this workshop at 4:15. I know on the schedule there is a little bit of confusion. So 4:15. But if you need to cut out early, just quietly get up and go. We won't, we will take a picture of you and post it on Facebook. But other than that, as you're leaving. But yeah, no, it's all good. So we have 2 speakers for you for this workshop, and I'm going to read their bios and then turn it over to them. So Dr. Mary Jo Alvarez Rodriguez was born and raised in San Antonio and is a first-generation college graduate. Let's give her a round of applause for that. She attended San Antonio College and then transferred to Our Lady of the Lake University, where she earned both a bachelor's and a master's degree in social work. After graduation, After graduation, she worked in various positions for approximately 10 years until she was recruited to teach social work at St. Edward's University in Austin, Texas. While in Austin, she was encouraged to enroll in a doctoral studies program in the summer of 2006, and through hard work and perseverance, she is now Dr. Mary Jo Rodriguez. So she has a PhD from the University of Texas in Arlington, and she taught for 36 years and continued to practice in a local, it's hard to believe because you're only like 40 years old. So,
it's actually 16 years. 16?
It's typo. Okay, 16 years. That's a significant typo. That's a 20-year typo. So that's good. So I'm glad you're here to clarify that. So she has significant administrative and clinical practice experience and has developed and implemented many programs in San Antonio that address the gaps in service for vulnerable populations, and that's one of the things we'll be talking about today. There's so many other things on her bio here, but she's at St. Dominic Catholic Church, and she set up a mental health ministry there, and she's collaborated with NAMI Bridges to Care for mental health training, and St. Dominic was the first Catholic parish out of 67 other congregations to join this faith-based movement. So let's give her a round of applause for that. She married her high school sweetheart. They're still married, right? They have 2 amazing daughters and 4 wonderful grandchildren. So one of her greatest accomplishments right there. So that's great. Yeah. All right, Olga Rodriguez. She is senior pastor's wife. Whew. Let's give her a round of applause for that one. Yeah. For many years, my wife can attest to the fun that is. So she brings a faith-based compassion to all the projects that she implements and manages. Olga has more than 34 years now. Is that a correct number? Okay, good. All right. I didn't want to make another 20-year issue of that. So 34 years of experience in event planning and community engagement activities, cultivating strong leadership, teamwork, and communication skills. She has demonstrated expertise in her church leadership role, as well as in her professional and personal projects. And so, and I have seen that firsthand. Olga's positive attitude, and I've heard that firsthand too, and her willingness to walk alongside the vulnerable and underserved has compelled her to use her abilities to help those in need within the church and the community. The scope of her training has equipped her to lead workshops and seminars like this one as effectively and efficiently manage her diverse projects. She and her husband have been married and in ministry together for, and they just left that blank, so for how long?
34 years.
34 years. See, there we go. Awesome. And they have four sons, 4 daughters-in-law, and 7 grandchildren. Wow. Twins. All right. Y'all, we have incredible speakers here for you for the last workshop of the day. And so give them a round of applause as they...
Okay, so good evening. We're really excited to be here, and thank you for being here today. This is Nami has come such a long way in establishing this conference. Today, I looked at the agenda, and it's too bad I'm here because I wanted to be at the other 2 workshops. I have a lot of my friends presenting at the other 2 workshops and people I've worked with for a long time. But on that note, I wanted to share a little bit about my journey into the mental health field, just to kind of give you a scope of things. I don't only have professional experience. I've already been a clinician for many years. My first job out of grad school was in the jail in San Antonio. It was in 1985, and I got hired there to oversee a program for women, unheard of before. I never even heard of this program, but it was a program, a parenting model that had been adopted from prison up in Pleasanton, California. It was a parenting program. They decided to bring it to their county because they felt it was a way of managing the women, right? So they wouldn't get out of control. But anyway, it was a parenting model. It was called the Match Program. That was in 1995, and that program still exists. And I think just working with the women, I was very young. I just had my master's in social work, and I will tell you, it was a godsend, that job, because it really prepared me for many other things that happened in my life that kind of had a pattern, right? I knew what God was calling me from that day. But those women, because of my inexperience and being so naive and young, they ate me for breakfast, lunch, and dinner. It just challenged me beyond my depth. But I got really grounded. I started to learn about mental health at the time. But then I went to work other places, and I kind of left mental health, the mental health field, went into prevention. And then God recruited over to St. Ed's, where I started teaching. But I did some work while I was there because one thing that always became important to me is that, especially being an academic person, I always felt that I wanted to bring a live experience into the classroom. So all the years I taught at St. Edward's, I also practiced. And that was really something that was very helpful to me in my teaching. Because I really struggled when I went to teach. I had never taught before. I had only taught 1 course at Our Lady of Lake as an adjunct. But they wanted a Hispanic so bad at St. Edward's because they saw an influx of students coming into the university, right? And there was no Hispanic faculty. That was, what, 80 miles away? I could have been 8,000 miles away because I really felt alone and lost and really right. But one thing I learned there is how to ask for help. And so my director, the director of the social work program, really listened to me and hooked me up with some professors there. They were really excellent. 2 years later, I got a teaching excellence award from 2 of the schools at the university. I was very proud of that, and hard work pays off, right? But anyway, I got my PhD and then decided, I'm going to come back to San Antonio. I want to go back home. I come from a large family, large Catholic family, 14 kids. I'm number 3, right? And they're always, come back, coming home, I miss you. So I came back to San Antonio, started teaching at Our Lady of the Lake, and kind of got burned out after I taught for 3 years. And I had heard everything that was happening in Bear County, especially with the justice involved. And I already developed an interest in the justice involved, right? Because I worked at the jail with the women, and it was amazing work. And I said, man, I want to get involved with that. Be careful what you ask for. I wanted to get involved with that, and Lord and behold, I a friend of mine who was director for the mental health department in the jail came up to me and she said, hey, you know, if you want to go back to practice, University Health System is looking for a unique person. She said it very well. Very unique, very dynamic, knows what they're doing, blah, 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 everything to entice me. Well, anyway, she said they're looking for somebody to start up mental health diversion at the Central Magistrate Facility. Does anybody know what the Central Magistrate Facility is here in town? Anybody? Good. Because it is the entry point to criminal justice. If you ever get arrested, that's where you will be taken. And now it's part of the jail, right? They've integrated into our main jail, but back then it was over on South Frio, next to Municipal Park. In fact, it was part of the building, but it was way in the back. It was a dirty, dark, dingy place. And so I asked, well, where would I be? She said, you'll be at the MAGS. I said, well, where's that? They called it the MAGS, right? I said, where's that? She said, well, let me take you over there. So we went over there, and I went in there, and I'm like, oh my God, it's a big, dirty place. Like, I'm telling you, it's big, it's huge, it's dark. And there was a lot of action there. It was surrounded by cells, and we were standing, and I was kind of casing the place. And I was like, sounds kind of interesting to me. It looks pretty good. But I like action. And so I said, well, where's my office going to be? So she kind of looks around and you're standing in it. And I'm not kidding. I was literally standing in it because they put a desk, they put a computer, they put a printer and a phone, and I went to work. And the first thing I did as a social worker, being unknown to the whole area, and they never had a clinician there, right? And so the first thing I had to do is build all those collaboratives and partner with people and make connections in the facility and outside, right? But, you know, God bless me, it was sort of my forte when I got there, right? I mean, before you know it, people were yelling at me across, Doc, what do you want us to do with this guy? You know, it became like that. And it was such a great job. I loved it. I learned so much. I got grounded in mental health because I literally did mental health live every day. I mean, it was live, front line. I mean, I was right there. The officers would come in and sit somebody down and said, Doc, this guy is crazy. You need to do something. That's kind of the way it happened, right? I loved it. I really loved it. But I really learned a lot about mental health. And it went beyond that because I'll tell you, and sometimes I'm not kidding, I worked at St. Edward's, I worked at the Lake where I had a pretty nice office. And sometimes I would sit there, what were you thinking? You left academia, you know, all that comes with that, the respect, the prestige to come here, right? But God had greater plans that I couldn't ever imagine. And that was my preparation. And then one day I got a call from my brother, right? And he brought it all home. God brought it all home to me because I got a call from my brother and he says, hey, I need to talk to you. And I said, well, what's going on? He said, well, I need to talk to you about our sister. My sister lived with my brother and his wife. I said, well, what's going on with her? And he said, well, I think there's something wrong with her. I just don't want her, and I remember the exact words, I just don't want her to kill herself in our house. And I said, well, what do you mean? Well, apparently there have been some dynamics already that suggested she might have some form of mental health issues, right? And my family wasn't prepared for that. They didn't know. And by the grace of God, I knew exactly what to do already because I was already 3 years into my job there. I made a lot of connections and knew psychiatrists, you know, on a first-name basis, and that's what you needed in that kind of work. And so I said, well, let me talk to her, and I was able to convince my daughter, my sister, to come and stay with me. I said, why don't you come and stay until you find a place? I'll help you. You know, you can stay as long as you like. And so I said, maybe 3 months, a year, whatever it takes you. 7 years later, my husband's like, when? When? Do something, you're a social worker. through. She jeopardized it. She just didn't follow through, so I had to call and make an appointment, went with her, spoke for her, and then I personally went and helped her find a place, and we all moved her fast. I couldn't believe how much she packed into one room in the course of several years, right? But I'll tell you, I learned so much from my sister, and I always am blessed. And I was so blessed that I have been at the Mags. I was able to help her. Today she's thriving. She has her own apartment. She loves it. And you know what? To take it even a step further, after that, it's become evident that as some of my nieces and nephews are growing up in this complicated and complex world, right? They're already exemplifying some mental health issues. And so, now I continue to try to link them into treatment because, one thing I'm going to tell you that today there is help. There's lots of help today by the grace of God. We're in a good place. So today we're going to talk a little bit about, just kind of working with Latinos and Hispanics, and most of my work has been with that population. And today I retired from the University Health System last year. And now I work for the Archdiocese at St. Dominic, where I'm a counselor, and brought in a mental health ministry that is thriving. We did our Bridges to Care training with the first Catholic church to do it, as Justin told you. I'm so proud of that. We've got other churches taking interest, and we have a lot of Catholic churches, okay? So we're on a mission to get them all on board. Because can you imagine how far reaching this could be by having people training? I mean, NAMI gives you 20 hours, right? So anyway, I wanted to share that with you, and then, do you want to say?
Definitely. My take in all this, in dealing with the Latino families, is because my husband and I have been in the ministry for 34 years, and if we know, and if anyone's involved with the church, we see a lot of people in our churches that have mental health issues, don't they? Illnesses. But a lot of times, as a pastor, they're not ready to help that person. Sometimes they can deter them. It can be seen as very negative. So this is where I come in this piece of our conversation, is the other side of the church. They can either close the doors, pretend they didn't hear, or they want to help, but don't know how. And sometimes there's a real fine line that we can't cross because a lot of times the pastor or the staff is not certified to give that professional counseling, and sometimes they cross a line where they do give that counseling. It ends up to be very bad. And I think y'all have a lot of people that are here, or friends that are here today, have witnessed that, and you're a professional, and you've talked to families that have gone maybe to the church or to a place that weren't certified to give that professional help. And again, this is where I want to bring my expertise in being in the ministry for these many years and working with the faith community and the Hispanic Latino community on how this is seen. A lot of times it's very seen more as chiflazón. Who knows what chiflazón means? What is it? What is it? Yeah. You're just being silly. You're just being, there's another word that you said, spoiled. You're just spoiled. There's, what you're going through, you're just being spoiled. So, again, Mary Jo and I, we're gonna just, have this conversation with you and bring both aspects. Mary Jo is your professional. I'm the one that's in the church, serving, and again, there's a fine line that needs to be communicated to our faith leaders. That if we don't know what to say, we have to gently, have them see a professional. But again, there's a lot of times that that's not encouraged because you don't have faith. Where's your faith if you're wanting to seek professional help? It's seen down upon the person that's wanting to seek that help. So again, together, we're gonna go through this. We're gonna create this conversation. We're gonna create this space. I'm not sure, I think we're gonna have a little bit of Q&A right at the end.
Yeah.
So, again, this is where we want to bring both academia and one that is involved with the faith community, dealing with the people that are in our Latino communities.
You know, and needless to say, everything that we're going to present is not mutually exhaustive. So if you have some ideas that you've used, strategies, interventions that are effective, please feel free to share it with the rest of us, okay? So let me move through this PowerPoint. Okay, so I just want to do a little grounding because I have taught in academia for so long, and I like to bring in that kind of perspective as well, kind of looking at the research, looking what's out there in regard to this topic. It's very important. So when we look at Hispanics, LatinX, right, it can be any race or color. Includes Mexicans and Puerto Ricans, Cubans, Central Americans and South Americans, and mostly people that speak Spanish. And today, the largest population among Hispanics is Mexicans, right? We continue to grow. In fact, I'll share something funny with you. When I was at St. Edward's, I was in my class one day and I made the mistake of saying, we're going to overcome now. It's our turn, you know, just jokingly to the students, and somebody complained. It wasn't a Hispanic student. I was just joking because I was like, so anyway, of course, Hispanic is tied to the Spanish language, and that's tied to Spain, and thus they reject giving birth. I mean, thus, because of that, they gave birth to the term Latino, because a lot of people didn't want to be referred to as Hispanic. So Hispanic excludes Brazilians because their language is predominantly Portuguese. And so LatinX is a more progressive term that is gender neutral. It's non-binary, binary term for Latino that pushes back on the gender language to be more inclusive. So identity and culture are complex, and there is no one Hispanic or Latin culture per se. So just looking at us in general, you know, we're very diverse, and today we see a very changed world. It's radically changed in the last 10 years. We are now the fastest growing minority population. We're ranked the second largest ethnic group in the U.S. 18% of us are Hispanic Latino in this country, and again, Mexicans are the largest. Texas also is the third state with the largest Latino population. California is first, of course, and New Mexico, surprisingly, is second. Yeah, so when we look at Hispanic and Latinos, we see that they embody differences altogether and many similarities, of course, as well, that are grounded in many dimensions of history and identity. There's many classes, of course, we could just speak on that topic alone for a long time, but we're not going to do that today. Okay, this is just a chart that kind of shows you in terms of mental health issues, 18.3% of the U.S. population are estimated to be Latino or Hispanic, and of those, 16% have reported having a mental health illness in the past year. And that's over 10 million people, and that's more than the number of people who live in New York City. That's huge. And it continues to grow, folks. And the more we get educated, the more we get informed, the more we learn about mental illness, it's evolving, and more people are stepping up. I mean, whenever you look at research, you look at statistics, you look at what's out there, you know, always question where the data is coming from. And we know today, right, whenever we compile data, as I did a lot of research in my PhD program, whenever you compile a lot of data, it only includes those people that you have access to their information. But yet, a lot of people that are mentally ill are not represented in the data, right? Because they're not in treatment, you know, especially Latinos. So we're going to talk about some of those barriers as well in this talk. So some cultural considerations when we look at this population. So these aspects, just looking at all the changes, all the complexities inherent in the language, they're becoming more and more evident. And these aspects really provide us our key, right, to having a culturally responsive and racially conscious approach to service providers. And we still continue to struggle with people not utilizing, Hispanics not utilizing mental health services. Treatment approaches today must consider cultural dimensions to promote effectiveness in practice and services. And we all know that. We have a lot of training on being culturally responsive, culturally sensitive, right? I mean, there's training everywhere today. But yet I have people that walk into my office and they talk about the experiences, the negative experiences they have because even their doctors don't understand them. They don't understand their language. They don't have people that speak Spanish. And so they don't feel that their needs are being responded to, right? I mean, it's still happening to this day. So that makes this whole area of cultural diversity and cultural differences very important. So again, when we look at this population, we know that mental health tends to be a very stigmatized topic. The population also faces unique barriers that affect access to health care. We'll talk about some of those. And the lack of health care, as you will know, can be detrimental, right, to their mental health, of course. Some of the studies, epidemiological studies, show that up to 60% of Latinos meet the diagnosis for any lifetime mood, anxiety, or substance use disorder, and 30% for psychiatric disorders. And serious mental health conditions for this group are on the rise. Some of the latest statistics reported by NAMI, they find that 1 in 5 people, adult people in the U.S. today, that experience a mental health condition. And it's higher among Latinos, right? It really is a lot higher among Latinos because they have many more challenges. Would you agree with that? That Latinos have more challenges, and language tends to be one of those major challenges. So we also know that mental health conditions for this group tend to be on the rise, and they're growing too, leaps and bounds among the young people as well. Statistics show they're also 1 out of 6 youth today, 14 to 20, I think, have a mental health disorder here in the U.S. today. So still, despite that it's a growing issue among our Latino populations, we still lag behind tremendously in accessing health care, mental health care. So some of the common mental health issues are generalized anxiety disorder that are common among Latinos. When I started working at the church, and every time working at the church, I always had a dream, and I prayed to the Lord that one day when I retired, I wanted to work at the church, and God granted me my dream. I really do. I like it a lot. I met some really good people there that I never knew as parishioners. And when I first started working there, I was just shocked by the number of people that would come to see me for anxiety and depression. I think practically every female that came into my office had anxiety and depression, right? I mean, it continues, and now I'm finding that some of the children too have anxiety, and we're trying to delve into addressing the needs of the children as well. We're not there yet. So, children born to immigrant parents have higher rates of mental illness in parents. And, as you look at the world today and everything that's happening with immigration, that's a cause for alarm, right? It's really alarming because We have so many immigrants that there's no way we can address all their needs and everybody else's needs. The systems are getting overwhelmed. We don't have enough Spanish-speaking providers. We don't have enough Spanish-speaking professionals. You know, when I started working at the church also, my Spanish was so, I lagged because I hadn't practiced it. You know, when I worked in the jail for 11 years, I worked with the university health system. I rarely had a client that spoke Spanish, right, or wanted to be counseled in Spanish. It was mostly all English speaking. So I was really challenged at the church because I had a lot of people coming in that spoke only Spanish. But you know what? Today, I can keep up with the best of them. Yeah. Everything happens for a reason, and God bless me. My Spanish has gotten more proficient, and I feel better. You know, I can actually talk to them and laugh with them and joke with them and the whole gamut. But anyway, it's been good. So you know, just to tell you that if you're challenged in that way, seize the moment, because you will become so much better for it, and you will be able to help people better. You know, and they're so understanding. I will tell you, I would get stuck on a lot of words, and they would pull me through. They actually would. So, only 33% of Latinos, adults, receive mental health treatment each year, compared to 43% of the general U.S. population. So, more issues. Trauma, right? We talked about this immigrant population, people coming in, refugees, seeking asylum, the whole gamut. And you can just imagine the extent of their experiences just getting over here. I've heard some of those stories from some of the women, some of those families, right? It's like, that's major trauma right there. Just making a journey over here, right? And then, it's just, we don't have, trauma is a big issue today. And I started trauma programs in the jail in San Antonio here. I've been for 5 years with men and women. So I learned a lot about trauma, and I learned how much it truly helps to have a clinician who knows about trauma, because most of us have trauma. The statistics reveal that most of us have experienced some trauma in some way. What I never knew is the extent of the trauma among the justice involved. Their trauma was severe. It was really severe. So I really had to step up my act and my training and the whole gamut to be able to respond to those needs. But being able to be helpful in that way really makes a difference in people's lives. And they do get better. They get better. But we don't have enough trauma therapists, right? We don't have enough trauma therapists or trauma counselors that are really trained for people that don't have health insurance. And the majority of clients that I see don't have health insurance, especially the people that were justice involved, right? So we really have to work on that. Yes.
I have a question.
Yeah, no, that's okay.
Into your speech. You guys have offered training programs to be able to contribute and help people who's passing a trauma, PTSD, mental illness.
Today, at the church, we're part of that NAMI Bridges to Care. Are you all familiar with that program?
Yes.
Okay, we're part of that training, and we have 9 of us already that have been trained. I'm the only clinician, right? But everybody else is a parishioner, but they're already using that training to deal in their everyday lives and at the church, because they get some grounding, right, on how you deal with a person that has mental illness, because the church is a place that Latinos and Hispanics, a lot of times, it's the first place they come to seek help. So it's a very timely thing, this Bridges to Care. I love it. I've been promoting it all over the place. And I hope every church in the diocese jumps on board with that, because that's the start, okay? That's the start to make more people be able to help.
My
Yes.
second question
Yeah.
is, do you guys have a grant that can be able to help us, the people are interested, that we are interested to help. I'm multilingual,
Okay.
and I do speak Spanish and Portuguese,
Mhm.
and due to severe PTSD and by sexual assault 2 years ago, my life has changed tremendously. I usually work in the financial area for the fourth biggest bank in the United States. And since that, I want to be able to help people that they pass for the same situation that they pass.
Mhm.
That is why I'm here. One, the other is because we are busy. Two, is just to find a association that provides a grant to continue my education and to be able to help and serve people.
Okay, let me just offer something to you, because I hear you, and I'm so glad you're here wanting to do this, because we need everyone, right? I mean, this is a big area that will continue to grow, leaps and bounds, but I will be happy to talk to you afterward and give you some suggestions, okay? Thank you for sharing that. All right, so, okay, so I talked about the little migration journey and social injustices that cause trauma, PTSD, and if they have trauma, which is very likely, because remember, a lot of individuals that are coming in from other countries, right, are experiencing hardships up there, like war and all this. So they already have trauma that's exacerbated and re-triggered. So if you're not really trained in trauma, I suggest you get more training, because we're all going to need it, okay? So the experience and manifestation of mental illness can be influenced, right, by a person's social and cultural background. It can affect how individuals communicate their symptoms, influence their understanding of their illness, and determine coping mechanisms. So we have to keep that in mind when we're working with individuals, and generalizations about culture and beliefs also can perpetuate stereotypes. And that continues, and that's why we continue to develop strategies to reduce stigma, right, towards the mentally ill. So culture also affects the way patients describe the meaning people give to their illness. So some approaches for addressing mental health issues, of course, we continue to familiarize ourselves with mental health resources that address the needs and, provide resources for Hispanic, LatinX professionals, even to a point that find out who is Spanish speaking, right? A lot of people need people that are Spanish speaking. You can let clients know to ask for their primary care provider for a referral to a mental health program, or others that know local resources. And there are some programs, like I know in the substance abuse field, UT Health is doing some training for doctors to sensitize them, right, to some of these issues. So I think, let me say something very positive that I'm excited about. The Archdiocese in San Antonio, they have a pastoral center and they oversee a lot of the programs. And mental health has been one that they adopted because they hired this young woman, and she's getting ready to do a training for our priests and our priests, pastors, and other clergy in the Catholic Church on mental health. And I'm so glad, because she's a strong advocate, so she and I are kind of working together on the mission of putting it out there to other churches, right? Because we want everybody on board. And I have no doubt that will happen in a matter of time, because it's the right thing to do, right? And it's needed. So also find out what programs have access to Spanish-speaking mental health professionals to decrease language barriers. And, we have a list that we compiled in our office of Spanish-speaking therapists, right, that we provide Now, our mental health ministry, and this is open to anybody, I want to pass this on to you because it is a resource. But our mental health ministry at St. Dominic does a monthly mental health or related workshop for free. The first one we did, Mental Health 101, we had 70 people show up. And it wasn't our parishioners. There were people from all over coming in because they want to learn. Because they're even seeing it in the churches. But that is open. And this Tuesday, we do it every last Tuesday of the month at 6:30. This Tuesday, we're having Rise Recovery that's going to be talking about substance use disorders. And they're here, presenting here. Next month in October, Patricia Castillo with the Peace Initiative is coming to do domestic violence. And she's always a standout, right? And she's dynamic. She's a good friend of mine, too, for years and years. But anyway, and then we have Bear County. Bear County Behavioral Health Department, they're coming to do a workshop, too. So it's some pretty dynamic workshops that are open to everybody. You can even have clients attend. So I just want to pass it on to you. So let's move into real quickly cultural barriers. We know for a fact, those of us that have worked with Latinos, probably everybody in this room, that many of them view mental illness as a weakness, right? And it's just not Hispanics, but men, right? I have a lot of women coming to my office, they have marital problems because they think their husbands are crazy. Está bien loco, right? They say that to me a lot, and they start to describe the behavior. I'm like, right on key. But some of these guys will not admit to it, right? And they're stuck. They're really stuck. And it's so sad because these women want to hold on to their marriages. They're Catholic. They have kids, and they want to save their families. But these guys are so stuck in that. So that's something that I'm dealing with right now, trying to come up with strategies to kind of move on through it. Okay, so others feel, they feel they're going to be stereotyped, labeled, like they're crazy, right? We hear that a lot, right? And then, of course, the stigma, and that's why we continue to do these workshops to foster awareness, so we can all work towards reducing that stigma that mental illness still has. And few of this population actually talk to their primary doctors about mental health, right? And because of shame too, right? They're ashamed, and why do you think they don't talk to their doctors about it? Anybody? Yes.
I think doctors often ask about mental health things in a very bad way.
Yeah.
So they'll say something, it's hard enough to talk about it anyway, and then they'll say something like, you don't have problems with fill in the blank, do you? And they say it in a way that it would be very hard to admit.
You don't want to admit it, okay? There's shame there, right? Problem, number one.
And it's like people are trying to be respectful of their doctors, so they're agreeable, and they're like, oh, no, that's not a problem. And it might be a huge problem.
So that's a good point, right? Because that kind of suggests to us that even the language we use is important, and we have to be cognizant of that. Yeah, in fact, the NAMI training includes, the Bridges to Care includes a course called Companionship. And some people that are on our team that went through that training, they said, oh my God, I realized that I was talking to my son in the wrong way. I'm very negative about his mental illness, not recognizing that he's not even realizing what he's doing because of the mental illness, right? So, those trainings are invaluable. Okay. So some of the other barriers are the disconnect between American psychotherapy and needs or values of Hispanic populations, right? Sometimes these trainings are very structured, they're very clinical, and all these things are very unfamiliar to some of our individuals seeking the help. They're also more likely, and there's been a lot of research supporting this, that for us Latinos, oftentimes, because we're so family-oriented, and familismo tends to be a core value, that we, particularly when we have a very supportive family system, we would rather go to them first, right? We would rather share with them. And of course, you have individuals that do not want to talk to their families, right? But a lot of us with supportive networks will go to them first. And sometimes, I mean, think about it. The families sometimes are not equipped to give them the information they need. And sometimes, right, they give them misinformation. And sometimes it's even discouraging them from seeking the help they truly need. So nowadays, the research is suggesting that's why it's important to engage the family in the process and bring them on board, where you can. And I try to do that at the church, right? Try to engage some of the families. But I kind of leave it up to the client, get their permission. So in other sources they seek help from, of course, is clergy, right? And there's been literature that supports that as well, that suggests that people are more apt to go to their church seeking help for mental health or other related issues. So it's good that we all have people in our churches, and this training is non-denominational. So it's great because any church can be part of this process and have a group of people that are trained. So of course, the negative perceptions that persist towards mental health and acculturation, right? And you have to recognize the levels that people are in terms of embracing the dominant culture, right? Because that's also something that factors in. Others are the distinct lack of Latino psychologists. We don't have enough professionals. I know I worked in the jail for many years, and let me tell you, for years they tried to get a number of psychiatrists, right? We had one psychiatrist that is still there, right? And luckily he speaks Spanish, right? But we could never find another Spanish-speaking psychiatrist. Psychiatrists are in demand to the point that now nurse practitioners are being trained, right, to function in that role. And they even have a specialization that prepares you to be trained in the psychiatric field because there's such a demand. And remember, this continues to grow. So that they can provide medications, because there's a lot of LPCs and LCSWs that can all work, provide therapy, but they can't prescribe medications. And I wouldn't be surprised if one day this whole area moves in that direction, because we just need so many more people that are able to do that in conjunction with therapy and assessment. So previous negative experiences related to language, discrimination, or poor treatment is also something that dissuades people from seeking help. And of course, the lack of confidence in the ability of us to deliver the services, right? Some people lose their trust in the system. And stigma. Stigma is a big barrier to this day. So these are just some theories for understanding cultural underutilization of mental health services. There's two categories, the barrier theory that's been used, and that includes all these barriers, some of these barriers that I've talked about, and the alternate resource theory, which includes things like seeking out others, like your priest, or some people go to healers, like curanderos, right, to help them with these type of issues. So the implications of this is that familismo, like I mentioned, is a core value in the Hispanic culture that's relevant to the pathway to seeking help for mental health. And it includes not only the family, but relatives and fictive kin, other people that, for example, children to us, like babysitters, and Latinos with supportive social networks. They're also less likely. If you have a supportive network, you're less likely to tap into mental health treatment, per se, right, from professionals. Okay. if you don't have a supportive system, you're more likely to use mental health services that are available in the community. So, yes.
Clarify that, so if you're saying that someone has a good community and family, is it that they don't need the services, or it's a barrier to service?
It's a barrier. They need the services, but because they have family, they go to their family, they talk to their father, their sister, their tío, and who a lot of times misinforms them, right? But if you don't have that, then you're more likely to go. So that makes us very important because we're probably the ones that are going to be referring these individuals to those treatment resources, right? So just something to be aware about. So again, they're not the optimal sources of information because a lot of times they may not have the right information. And still, the family network can still help to identify need for mental health, especially when there is added stress and disruption to the group. And let me give you an example. In our workshops that we're doing monthly, we have a lot of older women that come to those workshops, and they are really despondent, right? They're really despondent. They're desperately seeking help because they have grown adult children who are already creating many problems they cannot deal with. I mean, even to the point that some of them have been exposed to violence, right? And they struggle, they struggle because their adult son is already exemplifying violence, particularly when, he has a disagreement and it's because of his illness. And these are older people and they don't have the physical ability and they don't have the skills to be able to handle something like that. But yet, they're caught between a rock and a hard place because it's like, it's Nemo. He's my son. I love him. I don't want him on the streets. You see what I'm saying? The police comes and they tell him, get him out of here. No, you don't need to be putting up with that. But they have this guilt because it's part of their cultura, right? It's part of my culture. You don't just throw your kids out. We should, but we don't. No, I'm just kidding. According to dominant culture sometimes, right? Independence, right? We're supposed to, but really, these families won't. And they rather suffer. They compromise themselves. So they've been coming to these workshops and it's been helping a lot, right?
Oh, right here.
Do you want to add anything? What are you doing over there? Come over here.
Oh, no, I'm going to stand the whole time.
Yes.
Come over here. You can add some stuff. You can add some stuff.
No, again, we go back to the piece of the faith community. And then the families. We have to, I know that we want to reach the Hispanic, Latino families. They're very family oriented. If they go to a school meeting, who do they invite? The whole family. It's just not money. It's the whole family. Because they want to include everyone. So to bring everybody on board on mental health, it's difficult. Because they're not going to see it as something positive. Again, in our Hispanic culture, it's very challenging. I don't know if y'all can hear me.
The other mic's working.
Okay.
The other mic works.
So, in trying to reach the Hispanic family, we have to learn the culture, okay? Whenever we go anywhere and we want to reach that certain community, and that's something I even learned with the work that I do. I'm a project manager that deals with CMS, Center for Medicare and Medicaid Services throughout the country. Sometimes I go to places that I don't know anything about. So I try to learn the culture, how I even have to dress sometimes, because if I show up with pants, it's not going to be acceptable in that area. So I have to go in a skirt or a dress. Again, if we're wanting to reach out to our Hispanic, Latino communities, learn the culture. They're very inviting. They're very inviting. Again, there's walls that are there because of the trust. They may not see you as someone as trustful. So how do we break those barriers to reach them? To let them know that we're there, that you're there to help them. So you have to build those relationships. Again, being in the faith community and working with my husband in the faith community, 34 years, I have seen many folks, even pastors, ask, and this is really sad, because I know of this one situation where a pastor found out that one of the children of one of their leaders was taking medication. And this is honest truth. He finds out that the child is taking medication. He asked one of the deacons, you know what, bring your family to my office. Bring him to the office right now because I found out that you are seeing a psychologist or a therapist for your child, and he's taking medication. And bring the medication that your child's taking. They come in, sit down, pastor gets after the leader, give me that medication you have. Gets it, and what do you think the pastor did? Threw it away. Threw it away in the trash can and said, you don't need this. All you need is faith. God. Yes, we all believe in God. I'm a woman of faith. I'm a woman that believes in prayer. I'm a woman that has seen God's power. But God also provides medicine. God provides different kinds of therapy for our families, for ourselves. So I tell you what happened to that child? Within 2 weeks, that child committed suicide. Now, what is the responsibility of that one pastor? He wasn't trained. I mean, yes, he loved God, and he's very knowledgeable of the things of the Lord, but again, he's not the professional in this area. He's not the professional, so we have to leave that, and we have to educate even our faith leaders very much into this, that if we're not the professional, we can't give professional advice. Direct them to the place that they do need to go, because that's where we need to advise. We can't take that responsibility. Again, it was very hard to hear that this child committed suicide due to the advice of someone that wasn't certified and wasn't a professional. Heartbreaking. That's just one. I'm more than sure that y'all have heard, as professionals, you have heard the stories like such as this. Again, there's a lot of good intentions. A lot of good intentions in wanting to help, but sometimes those intentions are not good. Unfortunately. But again, if we're trying to reach out to our Hispanic, Latino families, individuals, there's going to be walls that we have to break down. And again, how do we break those walls? Is by getting to know the culture. Get to know who they are. Don't assume that you know. Because when we assume, sometimes we mess up. Because we think that, oh, this is what they want. I've had, unfortunately, I've had someone say, oh, do you like tacos? Yes, I like tacos, but I like also hamburgers and I like other stuff. Okay, as you can tell, But again, we can't assume. When people see you, they can assume certain things. Again, my skin color, I'm a woman of color. I'm a woman of color. I am. But sometimes we say, oh, well, they speak Spanish. Maybe they don't. Or maybe they're from Mexico because she's brown. Right? Again, breaking down those walls and trying to reach out and help those folks that are having to deal with mental illness or substance abuse. We have to break down those walls and get to know them and build that relationship. Honestly, that's going to work. And if you gain their trust, wow, you've hit the goalpost. There's a lot of wealth in that. Again, as clinicians, professionals, I think there's a lot of work to be done with our faith community. A lot that has to do with education. The education piece is so necessary. Again, we mean well, we want to help, we're there, and we're trustworthy in the community because the people will come to the church asking for help. They're there because they want help or they need hope. Again, there's a line. There's a line that we should not cross. If we're not the professional, gently turn them over to the professional that is certified to do that. Have y'all ever heard of mental health first aid? Who's ever heard of mental health first aid? What is mental health first aid? Someone that wants to just kind of give a word on that.
It's exactly what it says. It's like first aid for bleeding or any other injury. It gives someone a skill that they can be a first responder until help gets there to kind of bridge the
Right.
person through.
Is the first responder for what? Mental health, right?
Yes.
So we become almost like professional or very good hearers or observers, right? Again, that's a great thing to go through. If you can go through a training of mental health first aid, that's wonderful. That helps out. But again, you know, trying to reach the Latino community, the Latino people, there's sometimes those barriers. And a lot of times they don't have access. Even, I think you had touched on this, about medical insurance and stuff like that. My work, again, is with Medicare, Medicaid services, offering that to the underserved and uninsured communities. Letting them know about what's available. A lot of times they don't know. They don't have access. So what do? They won't say anything because they can't afford to see anyone. But there are other resources that are available that are free. I know we have Stitch here. Raise your hand. Yay! I like to, you know, they're wonderful partners because I've actually referred a lot of people that I know to Stitch because, do y'all charge? No charge. Did y'all know that? Write it down somewhere. Stitch, S-T-C-H. And if you want to give a donation, they'll take it. Yeah, if it's $1 million. Yes, ma'am.
I want to testify the great service that Stitch offers.
Oh, great.
I was one of your patients.
Oh, wonderful. There you go.
Years ago. Last year.
Great.
And thank you so much for all your help.
That's wonderful. Yes, ma'am.
What's their phone number?
Oh, give them your phone numbers.
210-339-7576.
So there you go. You have someone that has the resources available. You know anyone that needs counseling. They're a wonderful organization, again, that are able to provide that. If they can't afford it, there you go. If they have a little bit that they want to donate so that someone else can be blessed, someone else can benefit from that, wonderful. Make that donation.
What's the number again?
The number?
210-339-7576.
Wonderful. Thank you. That's Ms. Doselli.
What does STIP stand for?
South Texas Children's Home Ministries.
Thank you for sharing that, right? And resources are important. You know, I'm a social worker, like I mentioned, by profession. And one of the things that I took to heart as an undergrad was learning about resources. Because there's so much that can make you or break you in this profession, right? So I can tell you like what programs here in San Antonio, because I deal with people without insurance. I know what programs they can tap into without health insurance. That's so crucial, right? So, okay, so let me move on so we can get through the slides. Yeah, what time are we done, Justin?
4:15.
4:15, okay, let me run through because this is important. So, as a way of being sensitive, right, to this population, we honor their cultural differences. So we've got to consider the significance of the central role of familismo, right? So it's important to be able to ask people, you know, what's their relationship with their family? That'll give you some insight in terms of the kind of support they have and whether that's going to be a strength, right, that you can utilize. As a social worker, one of the approaches I learned early on that I love is the strengths-based approach, where it kind of reminds me of trauma today. You know how trauma says it's not about you, it's about what happened to you? Well, the strengths-based perspective puts clients in the perspective of it's not about what's wrong with you, it's about what's right with you. And when we take that approach, we have more success at getting to first base with them, right? So always look for their strengths. Like my friend Olga said, assess the audience, the needs, get to know the population, the goals. And you know what? I always learn too, as a social worker all the time, that if I wanted to know anything about the population, guess where I'd go? I'll go to the source. They are the first ones to want to share their life with you. They really are. And it's a way of that you can very, very calmly, very effectively tap into their strengths. They love to share. They love, especially, and they love to be maximized that way. It brings out the best in them. So I always did that. And have knowledge about levels of acculturation. It helps you understand and the interplay in the people's lives that you're working with. Be able to provide a brief explanation on mental health in their language, the terms, you know. That's important because they don't understand those academic words, right? Simplify it. I have to do a lot of simplification for a lot of the clients I work with. Psychoeducation, I will tell you, the educational piece of our mental health ministry has been very effective, you know, in promoting awareness, where people are now starting to come out and talk about it. And that is the first phase of healing, folks. If you want to heal from anything, you've got to put it out there. You know, that's one thing I learned, really, really, that stuck with me with trauma. Your whole healing belongs with being able to talk about it, right? So we have to move people through. Also, small group, you know, small groups are very effective. And we're starting up a family, 5 of us got trained in our ministry. We're going to be starting up a family-to-family group that NAMI does at our church too. Because out of that group that's coming to our educational workshops, there's people that need more help, more specific. They need some place to share weekly, monthly. And so we're going to do that. I'm excited about that. Storytelling is very effective with Latinos, right? And boy, do we know how to tell stories or what? We can tell a lot of stories. I can stand here and tell you a bunch of stories. And self-disclosure, okay? Now, not to extremes. I worked in the jail for a long time, and I was really guarded in terms of what I would disclose, because it can go places, you know, lots of places in that place. So, but at the same time, it can be effective if used appropriately. And hands-on activities, a friend of mine said, you know what, I would do bingo cards with mental health words, and we would do them in our group. We were playing a game, but they were learning. They were learning these important words. And pretty soon it became part of their language. And one thing that always helped me in the work that I've done with Latinos is I like to if I was doing a group, I like to interview them first and get to know them as a person. So you know what, they came to my group and I knew everybody's name. And that was important, right? The identity, it's so important. You get to know them, you get to share that in your group and say, you know, Mrs. Gonzalez, remember you told me this about you, and they feel honored, right? They feel honored because you know who they are. And you bring it out in a good way. And then, of course, I think these are the same ones. Okay. I guess that's all I got. But anyway, don't forget about everything else you bring to the table, your skills, your attitude, you know, your attributes, your perspective. Everything about you. You yourself are the major therapeutic tool. Use it, right? Use it. So I think we have a few minutes for questions if anybody wants any. Has any, not wants any, has any.
All right. Let's give our presenters a round of applause. As a non-Spanish speaking person, I know that's crazy to think that there would be someone that can't speak Spanish in South Texas, but I can't. I very little. The approaches that they talk about are good for even non-Spanish speaking folks. And I found that to be true, and it was so great to hear that, just that affirmation. So thank you all for that in my own ministry. Y'all, there was a typo in our program today for time-wise, but you hung in there the extra 15 minutes, so kudos to you. Yes, yeah. Tomorrow, there are no typos in the schedule, so show up when it tells you to show up, and it's going to be another great day. So thank you for being here. There's also, I think when you scan the code, the barcode deal, you can find a evaluation form, and we'd love for you to fill that out. And I don't know, are there any printed? Yes, we have some printed as well, so you can grab those. Those will be very helpful to the committee, the planning committee for next year. Thanks, y'all. Be safe tonight, and we'll see you tomorrow.